Hey, gang, this is Gonzo Gonzalez with Ask Dr. Gonzo Anything podcast. Thanks for joining in. Today we have here in the podcast a national and international expert in mitral valve disease, Dr. Paul Grayburn. Paul, thanks for being here.
Thanks, Gonzo. I appreciate your having me on.
Cool. Well, listen, let's jump into the topic. Talk to me about what are the new and exciting therapies out there for patients that have mitral valve disease.
Well, I think that mitral regurgitation in particular, where the valve leaks, has a bunch of therapies coming down the pipe. Before I get into those, I want to remind the listeners that surgeons like yourself do minimally invasive repair of the mitral valve, through the side instead of through the front of the chest. And this is very successful, and it's the absolute top indication for mitral valve surgery today is to try to repair the valve, generally with a minimally invasive approach.
So how many centers can you say? Is there a lot of centers right now in the nation doing this type of therapy, or are there a number of them? How does that work out? Because I know that the American College of Cardiology and the Society of Thoracic Surgeons have now put in some guidelines as to who should and who shouldn't be doing these types of therapies in the United States.
Yeah, that's right. I don't know the exact number, but I would imagine there are at least a couple of hundred centers in the U.S. of mitral valve repair, although there's probably more like 40 or 50 that do a high volume.
And tell the listeners what exactly is it that they should be looking at when they're seeking for this type of care. Is anybody sort of meant to be doing it? Is there a particular structure for a program they should be looking at?
Yeah, I think if I were a patient, I would want to ask my doctor, my cardiologist, and my surgeon, is my valve repairable? Can it be repaired through a minimally invasive approach? And do you do that operation, and how many do you do?
Perfect. Are you part of a team right now that oversees this type of care within a hospital system?
I am. Yeah, we've been looking at our data within our system, and it looks really very good.
So one of the things that we do in Fort Worth, and for the listeners, Paul is probably the foundation, if not the cornerstone, for all these programs that we have. And the way that we do it, as well as the programs that Paul is involved with, they basically have a group of individuals looking at every patient, right? I mean, it's no longer mitral valve disease is a disease of one that's managed by one single individual, right? It's a multidisciplinary group, right?
Yes, and the guidelines in the United States recommend a team approach.
So who's involved in your team? How many team members do you have?
So we have surgeons, interventional cardiologists, imaging cardiologists, and heart failure doctors. And there's typically 3 or 4 doctors in the room with each patient.
And it's very different from what it used to be even 10 years ago, right? I mean, well, I would say 5 years ago, in which basically you just saw one doctor.
Yeah, that's right. Now there's a bunch of minds coming together, and it's sort of like a supercomputer when you have 3 or 4 minds in the same room, all thinking about what is the best approach for this particular patient.
And and I mentioned at the beginning of the show that there's probably a number of new and exciting therapies that are out there. But I think that, what you and I talk about when we see these patients is that there's not one way in particular to take care of patients with mitral valve disease, right? And that's where the new and exciting therapies that are out there come into play, because like Paul pointed out, we basically just do, in the past, we used to do just surgery, but now with a lot of these new revolutionary and innovative therapies, there are different ways to take care of mitral valve disease. Wouldn't you agree?
I do. And I think when you go into the operating room as a surgeon, you have a whole toolbox at your disposal. You have artificial cords, you have all kinds of different rings, complete rings, incomplete rings, partial bands. You have replacements with all kinds of devices. And the interventional cardiology approach is to try to mimic that and develop a toolbox of different things that can be used in the right circumstance, because every patient is different.
So before we jump into the new and innovative things that I wanted you to discuss, tell me about what is the major difference between a minimally invasive approach, or what are the major differences between a minimally invasive approach and the standard approaches that were done in the past?
Yeah, and I'm speaking as a cardiologist who sees the patients after the surgery.
Right.
Patients get back on their feet quicker. Both have some degree of pain, but the getting back on your feet, back to work, back to an active lifestyle happens quicker with a minimally invasive approach. The results are basically the same. It's just a quicker recovery.
And then that translates into length of stays that are shorter in the hospital. And to Paul's point, also getting back to your daily activities, it's a major difference. Okay, so tell me, let's go back into the discussion about, so minimally invasive mitral valve surgery has been something that has been revolutionized, and right now we can do it, and patients stay a very short period of time in the hospital. But how about the new therapies, things like catheter-based technology that are out there? Let's start with what do you have available for mitral valve repair if you wanted to repair a mitral valve?
Well, the first thing to talk about is the MitraClip, because it is approved by the U.S. Food and Drug Administration for primary mitral regurgitation, which basically means there's something wrong with the leaflets themselves. And that's been approved since 2013, and it is approved for patients who are considered to be too high risk to have traditional surgery.
So if I were a patient, the first thing that comes to mind is asking you, so how do I know that I'm too high risk for surgery?
Yeah, that's the decision that the surgeon is going to make. But there are many things that factor into it. One of those is age. The older, the higher the risk. One of those is having had prior operations. A big one is kidney failure or liver failure. So there's a whole host of things that can put you at high risk.
How about prior surgeries? Does prior surgery make you a high-risk patient?
It increases the risk, and there's always this threshold between how high is too high. Even if you're at a little bit high risk, surgery may still be the best option for you.
Okay, and you mentioned aged. Now, I can tell you that we've operated and had really good outcomes with people in their 80s and even 90s when it comes to open minimally invasive surgery. But how does age play out?
Yeah, age increases the risk, but you're right. A healthy 80 or 90-year-old can have mitral valve surgery and do just fine with it. It's just typically that as you age, other things are also not working correctly. Maybe the kidneys, maybe the lungs, liver, and all of these things are more likely to be abnormal.
Paul, tell me how do you put one of these mitral valve clips? How does that work out?
So the nice thing about the MitraClip is it's done through the vein in the groin called the femoral vein. So we basically put a needle in the vein, introduce the clip, and go up into the heart and put the clip on. And so typically our patients go home the next day.
And so how big is the team that has to do that?
Usually we have two people implanting the device and one person doing a transesophageal echo, which is an ultrasound technique that allows us to see what we're doing and put it in the right place.
So 1 day turnaround, basically from admission to discharge. That's pretty amazing, isn't it?
Yeah, that's the best part of the clip. The downside of the clip is it's not as good as a surgical repair. So in the hands of an experienced mitral valve surgeon, your chance of improving the mitral regurgitation is about 98%. It's certainly above 95%. And it essentially eliminates the mitral regurgitation. The clip gets you down to mild. It reduces the regurgitation, but doesn't usually completely eliminate it.
Okay. So we talked a little bit about the different things that surgeons are have in the operating room, and you talked about, or you mentioned rings and bands and all that stuff. Are there any of those types of therapies or tools being developed for catheter-based technology, so that the cardiologist and the surgeon could do it through a catheter instead of doing it open?
Yes, that's right. So if a ring is the right therapy, you can do it with a catheter technique. Now, none of those are currently approved by the FDA, but they're in research trials, and we'll figure out if how well they work, and anticipate that some of them will be approved soon.
What is going to take, or what's happening right now so that the MitraClip becomes readily available for everybody out there? Are there, because there are studies that looked at this from degenerative disease, but now we're looking at functional. And just tell the listeners what's the difference between one and the other disease so that they can understand where does mitral valve MitraClip being used right now in particular.
Yeah, so primary mitral regurgitation, or usually called degenerative, means there's something wrong with the mitral valve itself. It's abnormal. The leaflets that close the valve are abnormal. Secondary mitral regurgitation, or functional mitral regurgitation, the mitral valve is completely normal. It just can't close all the way because it's usually pulled apart by a dilated heart. And so it's not clear right now whether the MitraClip really works for that or not. There's a big study called the COAPT trial that is anticipated to have results sometime later this year. And if that trial is positive, I'm sure the FDA will approve the MitraClip for secondary mitral regurgitation.
Perfect. Okay, let's change gears and talk about mitral valve replacement. And so let me start by asking you, there are being some therapies developed right now to try to deliver, and I know that the FDA has approved for some of these percutaneous mitral valve replacement therapies, but in going back, just to put the listeners into a frame of mind, I know that there has been in the past everybody had to be repaired, but there has been recently some studies that came out of the CTS NET trial, which was a large multi-institutional and national trial looking at the difference between mitral valve replacement and mitral valve repair for a particular type of therapy for mitral valve regurgitation. What can you tell the audience about that trial and what did it show?
The CTSN trial was for secondary mitral regurgitation, and what it showed was if you just repair the valve with a ring, there was a surprisingly high number of patients who had recurrent regurgitation a year down the road, or 2 years. So
12 months, so a year, not even 2 years out.
Yeah, in 1 year, 32% had recurrent mitral regurgitation.
So 1 out of 3, literally.
1 out of 3. Now, 2 of the 3 did recurrent mitral regurgitation very well. Their heart got better. So learning to predict ones not to do, and those should probably go ahead and get rather than repair. So they don't.
Paul, you're breaking up there. Can you hear me? Paul. Well, I think that Paul right now is probably in one of those areas that he's driving back to the mitral valve program, and he's probably en route. Let's see if we can get him back. If we can't, we'll try to sort of reconvene this interview. But Paul, you back?
Yeah, I'm back.
There we are. We lost you. Okay, thanks. So let's go back. So you said that about a third of people actually develop mitral valve insufficiency within 12 months. Tell me. So how did that change the landscape as to how do we treat people with ischemic mitral regurgitation?
I think there are some people where you can tell that a ring is going to work and they should get a ring. And there are other patients where you can really tell that it's unlikely to work or has a high chance of coming back. And those patients should be replaced right up front. Okay,
perfect. All right. So then based on that information and what we have right now in terms of technology, tell me a little bit about what's out there in terms of mitral valve replacement that's new and exciting.
Well, I'm very excited about mitral valve replacement through a catheter-based approach, and we've done quite a few. The good news is that there's at least one valve out there that seems to be working very, very well. Been over 100 patients treated with a very low risk. And then there are other valves in the pipeline that look like they're promising. Early on, we've been putting these through the chest on the left side, through the tip of the heart. But very soon we'll be putting them in through the groin like a MitraClip.
And so has the FDA approved any of these valves right now so that we can treat certain types of patients with mitral valve disease?
They are not approved for general use by the FDA, but they are approved in what is called an early feasibility study, where the FDA is allowing certain sites to do these valves so that we can perfect them and make sure that they work properly.
So how about the patients? Well, so then let me go back. So then how about the patients that already had a mitral valve prosthesis put in, either a ring or a valve that's degenerated? Haven't we gotten to the point that the FDA has approved certain valve therapies?
Yes, that's true. They have. So if the patient has had a ring or a biological valve put in, it is possible to put a new valve inside of that through the groin using a valve called a TAVR valve, which is actually designed to go in the aortic, not the mitral position, but we can put it inside of a prior mitral valve replacement or ring in certain circumstances. It depends on the size and make of the ring and the size and the make of the exact prosthesis that's in there.
And that's just recently the FDA has recently approved that for use that way, right?
Yes, that's right. Valve in Valve was just recently approved by the FDA, and we've done quite a few of them at our institution.
Awesome. Well, listen, Paul, I know that you have a busy day ahead of you and you're driving in the rain out there. So stay dry and be safe going to work. Thanks for taking the time and being on the show. I think that this is going to be one of the best shows that we've actually done. It's because you're such a intellect and have such a great fund of knowledge. So thanks for being on the show.
Thank you, Gonzo. It was a pleasure talking with you.
And to the listeners, thank you again for tuning in to the Ask Dr. Gonzo Anything podcast. And we'll see you again next week. Thanks.